Sorry, I will show you mainly old data. But good ideas, I think. So these are my conflict of interests. Cardiovascular causes of hypoxia. Cardiovascular means, I believe, blood flow and blood flow distribution and pressure. These are the two aspects of cardiovascular. Let's start from blood flow. Time is short. And first problem is, how do we perfuse the lung? And we know, as an example, in ARDS, we have regions of the lungs which are indeed perfused but not ventilated. In the old time, we called that shunt or venous mixture generators. The blood comes out from these regions with the same saturation of the mixed venous blood. Does not get oxygenated at all. This is a drawing of an alveolus which is indeed perfused but not ventilated. As you see, the blood comes out blue, not because it's the blood of nobleman, but because the saturation is low. And so you know that when cardiac output changes, mixed venous oxygen saturation changes. In normal subjects with very low intrapulmonary shunt, the effect of cardiac output in arterial oxygenation is negligible, from 10 liters per minute to 3 liters per minute. But as soon as we have a little small shunt, 15% or even 30%, when the cardiac output goes really low, you see saturation going down. And when you are really sick, when your patient is really sick, then cardiac output becomes a major determinant of arterial oxygenation. I know, it might be obvious, but the first time that I thought about it, I found it new. Because in normal subjects, arterial oxygenation has very little to do with cardiac output within broad limits. In an ARDS patient, cardiac output is important because it changes mixed venous saturation. And the arterial oxygen saturation, if the patient has 50% shunt, the arterial saturation is made up 50% by good oxygenated blood and 50% indeed by mixed venous blood. So the arterial is a mixture of mixed venous and ideal blood. And this mixture, if you have 50% shunt and a mixed venous saturation 75%, will be 87% arterial saturation, which will give you a decent PO2 of 58 millimeters of mercury, or perhaps here you will say 10 kilopascal. But if mixed venous goes from 75 to 50, same patient, same lung, now your arterial saturation will drop down to 75%. And the arterial saturation will be an awful 40 millimeters of mercury, just because mixed venous saturation changed, just because cardiac output changed. So this is a simple message. The sicker the lung, the more important is mixed venous saturation in determining the arterial saturation. If the lung is normal, who cares? Mixed venous is not important for arterial saturation. Then matters are more complicated because what counts is the body. And then you have effects and counter effects. The time is short. I'm not brilliant enough to tell you many things in few minutes. But if you have really an interest in it, go and read these papers and old stuff, with good physiology in it. This is a paper by Luciano Gattinoni, 1975, showing you that under certain conditions, cardiac index, when cardiac index increases, intrapulmonary shunt increases. And this is in dog, and this is in humans a few years later, made by inert gases techniques. But these are details. The biggest effect is the effect of mixed venous saturation. Mixed venous saturation with a sick patient, 50% shunt, is 50% of what causes your arterial saturation. Now, the other side of the game, I'm finished with flow. I did not talk you about hypoxic vasoconstriction, of VAQ ratios. Takes too much time. But let's talk about pressures. Pressures, we think, are not important anymore because we don't measure them anymore. Or let's put it this way. We have echo that gives us volumes, and volumes rule the cardiac function. The heart, Frank Starling, is ruled by stretch, volume changes. But the body around the heart, including the lung, which is part of the body, is ruled by pressures, because fluid moves around due to pressure. So if you want to know how the heart works, you have to get good data about volumes. If you have to know what generates a bigger liver or an edematous lung, you have to know about pressures, which obviously are linked to volume in some ways. But the same argument that tells you that pressure is not enough to know volumes, the same argument tells you that it's not enough to know volumes to know pressures. But anyway, point is that the body, effects on body are regulated by pressures and not by volumes. So this is, I told you, I will show you all data. This is 1977. I was born already. I don't know how many of you were born. But anyway, this was published in the New England Journal of Medicine. Not many people read it. But it says, mechanical forces producing pulmonary edema in asthma. Asthma is bronchoconstriction, increased airway resistance. And point is that intrathoracic pressures during asthma, according to these data, are more negative than in normal subjects. This is the normal value, -6 with this, in these experiments. In acute asthma, it might be -28, -30. And this is due to the fact that the patient inspires and generates a lot of force around his lung to inspire. And moreover, he needs a very low intrathoracic pressure to maintain dilated bronchi. This is the conclusion of this paper, that the more negative the pleural pressure is, the higher the fluid accumulation in the lung, which is a measure of edema. You might be asking yourself, why do I show you papers that are 40 years old? Another paper, this is 30 years old. And where is Jean-Louis Teboul? Jean-Louis is one of the authors of this paper. It shows that when patients are weaned from mechanical ventilation, they obviously generate negative pressures in their chest, and they generate negative pressures around their heart, and sometimes their heart fails. The more negative the pressure, the more failing the heart. At those times, we had pulmonary artery catheters, and we used them, and they could measure that pulmonary artery occlusion, wedge pressure, left ventricular filling pressure, raised up to 40 millimeters of mercury, because the intrathoracic pressure went low. Jean-Louis Teboul recently reviewed in a wonderful editorial on intensive care medicine these data, and he made a rather complex definition of why we can observe cardiac dysfunction during weaning. But what I want to talk to you about today is this, let me go back, is this little thing in the corner, intrathoracic pressure, that in my view is the most important thing here, beside cardiac function, because some people have a bad heart to start with. Intrathoracic pressure is very important, particularly these days that we are very fond of assisted breathing instead of controlled breathing. Assisted breathing is very good, but we must know how to use it. And I believe we must measure what happens inside the chest. In these patients that were ventilated below tidal volumes, patients in assist control, they were rather dyspnoic because of the low tidal volume. So they generated huge negative intrathoracic pressures, and they got, as the title says, into acute pulmonary edema in ARDS patients. Please go and read this paper. These are data from the ARDS low tidal volume versus high tidal volume patients. And indeed, we know that inspiratory resistance may cause, as shown in 1977, acute lung injury and acute lung edema. So negative intrathoracic pressure, first of all, we tend to forget that tidal volume, high tidal volume, is as dangerous in spontaneous breathing as in controlled breathing. Moreover, a negative intrathoracic pressure, we know from the heart point of view, it causes left heart acute insufficiency if the negative is low enough. But the negative intrathoracic pressure is linked to the amount of support. The higher the support, the smaller the effort that we require to the patient. So the smallest support, CPAP, causes the biggest drop in intrathoracic pressure. And the higher the resistance, the lower the alveolar pressure. Up to now, I've been talking about intrathoracic pressure, but there is another important pressure that is the pressure inside the alveolus. And if the higher the inspiratory flow, the higher the difference between the pressure at the mouth and the pressure in the alveolus because of the resistive drop. There you can see that if you measure or compute the alveolar pressure, the lower the support, the biggest the drop in alveolar pressure. And This drop is in red is obviously due to the resistive component. We often forget that the RDS lungs are indeed baby lungs, small lungs. Small lungs have high resistances. The smaller the lung, the higher the resistance. 1 liter per second in a big lung is not a big problem. 1 liter per second in a small lung is a huge pressure drop. And you can see your resistance is proportional, inversely proportional, to the end expiratory lung volume. So RDS lungs have indeed increased resistance 2, 3, 4 times normal. And we can observe very low alveolar pressures in ARDS patients being weaned from controlled mechanical ventilation. The higher the inspiratory flow, the lower the alveolar pressure. And this is from Norman Staub, again, 1977. Alveolar pressure and interstitial pressure go hand by hand. When alveolar pressure goes down, interstitial pressure goes down. Then you all know Starling's law. The lower the interstitial pressure, the higher the edema. So we end up like this. Sometimes we make mistakes too. And we try to wean this patient. After 3 days, he got interstitial lung edema. Not cardiac edema proper, but he got sicker than he was because we asked him to work too much and we asked a too low intrathoracic pressure from him. So please, intrathoracic pressure is very important. Airway resistance is very important. And when you wean a patient to assisted breathing, measure something like PO1 or intrathoracic pressure, whatever is convenient for you. Echo evaluation of the right ventricular function. And I think this is my last slide. Thank you very much.